Good morning, good afternoon, and good evening. My name is Jennifer Thomas, and I'm Managing Director of Plug and Play in Cleveland. And we're pleased that so many of you from across the globe are engaging with us today as we present the next webinar in our series on COVID-19. Today's event is entitled Leveraging Hospital Innovation to Help Diagnose, Care for, and Monitor COVID-19 Patients. And we will specifically cover how our partner, University Hospitals, has created a unified command center to address the pandemic. So let's get to the agenda. First up, we'll have Neda Amidi. She's our Global Head of Health and partner at Plug and Play, and she'll briefly go over what we do at Plug and Play. But she'll also announce a new initiative called Social Impact and COVID-19, because it's become clear that the pandemic is going to have a far-reaching effect. And Plug and Play feels that we can do our part to protect the lives and livelihoods of the many people who will be affected by COVID-19. We'll then have a fireside chat between Dr. Eric Beck, Chief Operating Officer of University Hospitals, and David Sylvan, the President of UH Ventures. You'll have the opportunity to ask Dr. Beck questions after the chat, and our own Innovation Manager, Simon Moore, will be conducting the Q&A. After that, we'll feature 5 startups that are addressing COVID-19 through digital diagnostics, AI for healthcare, and clinical decision support. We've allowed also 1 minute each for the startup, so please get your questions ready, and Simon will be managing that Q&A as well. Before we start, I want to bring your attention to some upcoming events we have in the COVID-19 series. As you can see, even next week is really busy for us. First with an event regarding securing remote workers that is part of our enterprise vertical. Then health will be having another event on Wednesday, April 29th, and we're going to be talking about how we treat chronically ill and patients who need continuing care with our partner Eli Lilly, those who are not necessarily sick from COVID-19 but still need care. And then we have our InsurTech vertical will be discussing managing business in a pandemic. So there's lots going on, and we hope you can join us. But let's get right to our event today. First, I'd like to now introduce Neda Amidi, our Global Head of Health and partner of Plug and Play.
Thank you, Jennifer, and thank you all for joining us today. If we can go to the next slide. So just a quick little introduction about Plug and Play for those of you who aren't familiar. Plug and Play started back in 2006. We started off more on the real estate side and had a lucky building in downtown Palo Alto off University Avenue, where we were renting office space to some small startups like PayPal and Google and Logitech. And really from there, we started our investment practice, so where we invest in early stage startups. Today, we invest in over 200 startups per year worldwide, and we invest alongside the top VCs in the globe as well. In 2008, we started our corporate activities where we started engaging with corporations to really identify pain points in their industry areas and to match them with startups that address those gaps. And today we have over 300 corporate partners across the globe as well. And really in 2012 and 2013, we started our accelerator programs where each of these programs are themed into different verticals, where we have programs like healthcare, retail, fintech, IoT, across major cities and industries in the world, where we run these 3-month accelerator programs to really match startups to corporations. And lastly, I should mention our headquarters, where we have a 180,000 square foot building today in Sunnyvale, with over 300 startups in that building. And so today we run over 17 different industry programs. You'll see a list of them here, and we're excited to talk more specifically today about the COVID-19 initiative. So for our COVID-19 program, really the vision and why we started it was to protect the lives and livelihoods of those affected by COVID-19. And really our mission, it doesn't go too far off from our existing mission, but really to validate and scale solutions that restore communities and revitalize economies by connecting innovative technology with platform partners. So this is what we do at Plug and Play, really connecting the startups and technology players to the corporate ecosystem. And so we're doing this through this End COVID-19 program. So within the social impact and End COVID-19, we see this being a series, and why we call it social impact. Right now, we're focused on ending COVID-19. In the future, we may be going after other topics underneath the social impact umbrella. Within COVID-19, we really see healthcare being one of the dominant areas that we focus on, and today's event will be focused on purely healthcare. We also see supply chain being affected by COVID-19 and have done a series around supply chain. Enterprise tech and the future of work, as we've all, many of us had to go remote. How do we facilitate that more easily, and how do we achieve that? So Enterprise 2.0 has been a big topic, and we've run several webinars around that. And last but not least is commerce. So those are the 4 topics we'll be covering. Within healthcare, these are some of the topics we'll be going deeper into. So I think many are familiar with, the shortages on the ventilators, the point of care diagnostics, molecular diagnostics, how to stay healthy and how to stay fit while we're at home as well, to make sure that we have, check-ins with our physicians through telemedicine. Symptom checkers, so that we don't have to go into the hospital if we don't need to. So what can we do at home to better check our symptoms as well? So you'll see some additional topics here, and some of the startups you'll hear from today will cover these topics as well. So how the process works, it's not different from any other plug and play program, where stage 1 is really working with the business units and the partners to determine their engagement and their interests. Stage 2 is really going deeper into those interest areas and to see what the program focus areas will be. Stage 3 is more on the plug and play side. So our team, we have about 40 people on the venture side that will source, filter, and select the startups that fit the interest areas of the partners and the business units. And then stage 4, we would actually begin the program and start with the pilots. And then at the end, we would also have a demo day to kind of graduate the companies and celebrate the success. So this is the typical timeline as well that we have within Plug and Play, but this is really walking through kind of the COVID-19 timeline. So right now in April, we're engaging the pilot partners. We'll be having startup pitch events, and similar to the one we're having today, and we'll do that through August. And then we'll have deep dive sessions with those startups and the business units to really get deeper engagements and to set up the pilots and to move forward with those. That will take place through May through August. And then we'll conclude the program at our fall summit. This is where multiple of our programs actually come to a conclusion, and we'll be adding a COVID-19 series in September. So far, we're doing our spring and summer summit virtually, but hopefully by September, we'll be back in person to in-person events. Great, and with that, if you're more of an industry partner, you'll find my contact information here. Again, Netta Amidi, Global Head of our Healthcare Program. And then for startups, we actually have a website, pnptc.com/COVID-19, where you can find an application page as well as more resources, videos, and topic areas that you could find there and apply directly. Thank you so much for joining us. I will pass it back to Jennifer.
Thank you, Netta. All right, great. So let me introduce the speakers today. We have Dr. Eric Beck, and he is Chief Operating Officer of University Hospital. And Dr. Beck is no stranger to crises. At the onset of COVID-19 crisis, in his newly appointed role as COO, Dr. Beck was immediately charged with rapidly establishing and activating a system-wide unified crisis command center at the hospital, drawing from his prior leadership roles at the City of Chicago and his role with the American Medical Response as FEMA director in Dallas, leading their incident command response at the Ebola outbreak. And prior to becoming COO, Dr. Beck served as president of Ventures, the innovation, commercialization, and venturing arm of University Hospital. And before joining Dr. Beck served as CEO and president for the University of North Texas Science Center Clinical Enterprise in Fort Worth, Texas, CEO for Integrated Delivery at Envision Healthcare, and President and CEO of Evolution Health in Dallas, Texas. So deep experience in healthcare and crisis management. Welcome, Dr. Beck. We're so happy to have you. And then Dr. Beck will be interviewed by David Sylvan. He's president of Ventures. And at the onset of the virus, the Ventures team was tasked with various COVID-19 response initiatives for the healthcare system, primarily focusing on designing and building a sustainable alternate PPE or personal protective equipment strategy, actionable intelligence, and of course, data and analytics for the command center. So we're really interested to hear about that. And in addition, David was tasked with establishing strategic local and national relationships or partnerships in order to rapidly co-design tools and equipment for frontline use related to COVID-19. So David comes to Ventures, after a successful career in capital markets, where he led a derivatives trading and public finance investment banking platform. He's also currently an adjunct professor at the Weatherhead School of Management at Case Western Reserve University in the Department of Design and Innovation. So welcome, Dr. Beck and David Sylvan. University Hospitals has been an incredibly engaged partner with Plug and Play, and we're so pleased to have you share your insight today. I'm going to pass it quickly to Simon for a little additional details. Thank you.
Fantastic, and good morning, everyone. I'm very excited for the conversation this morning. Just before we launch off, just a few housekeeping items. So we are going to have a Q&A with our speakers just after the fireside chat. So if you do have questions, please use the Q&A feature at the bottom of your screen, just right in the middle there. If you've got general comments, etc., or need some help from our team, use the chat box. And so without further ado, I'm going to hand it over to David and Dr. Beck. And I'll see you guys soon for the Q&A. Take care, guys.
Thank you, Simon, and good morning, everyone, or afternoon, as the case may be. Appreciate you having us, Plug and Play. Thank you to Neda and Jen and Simon. We really value our relationship with you. We're looking forward to the pivot for the remainder of the year with regard to COVID response with both enterprise tech as well as supply chain. So obviously an important set of endeavors in that regard. Good morning, Eric. I'm sorry that we still seem to be geographically separated. Of course, everyone can see that Eric is still completely put together, and I'll be representing the sadly disheveled for the remainder of this crisis. But let's get serious for a second, Eric. When the severity and the inevitability of what we were going to face became apparent, as Jennifer indicated, you were immediately tapped to set up a unified command center. Not your first rodeo, as she mentioned as well. So perhaps my first question to you is your experiences both in Chicago and in Texas with regard to crisis management at scale. How did that inform the path, the methodology, the process that you put into play with regard to setting up UH's Unified Command Center?
Yeah, thanks, David. It's really interesting. I would say that while past experience is a great preparation, in many ways this is unlike anything I've ever seen before, and I think most of my contemporaries have not encountered an emergency of this scale and magnitude. You know, what's particularly interesting from sort of the academic perspective as a student of emergency management, this particular pandemic is unique in that it's affecting the entire country, in fact, the entire world, relatively concurrently, which means that the typical resources, the typical friends and mutual aid resources you would mobilize to support your region or your institution are also facing the same sort of crisis. that limits the ability to scale redundant resources and puts added pressure on things like the supply chain. It puts added pressure on the ability to flex or provide bench strength and replenishments and staff, et cetera. So really unique in that sense. Having said that, the common denominator to any sort of successfully managed emergency, in this case a public health emergency, is really built on the principles of the incident command system, which to kind of geek out on that for a minute is really the output of after-action reviews of wildland fires in California in the 70s. And they studied them and found that the interagency coordination was lacking, that left and right hand didn't have synchronization, all well-intended individual efforts, but that there wasn't the type of really ingrained coordination that they all wanted to see. And so out of that came a very structured approach called the National Incident Management System. It's been adopted widely in public safety, law enforcement, military. Internationally, it looks different in other countries, but same basic principles. And was adapted in the 80s for the hospital system. And so that's really been our foundation, is a structured, interoperable approach that helps us take something as overwhelming as the COVID-19 pandemic and think about it in a very structured, very interoperable way. So our partners here in town, our other healthcare institutions, our state are using the same process, and that's really been the way we've reduced the complexity into a framework that allows us to proceed. So very different than anything I've seen before, but the approach is similar to what others are using and what sort of recommended best practice.
So it strikes me that we're beginning to talk about what a return to a new normal looks like and what the post-crisis environment will be. Surely we won't go back to not having some type of centralized response, reaction, command, information dissemination platform. Isn't this an opportunity to sort of perpetuate what we know we should keep in a sort of standby mode?
Yeah, it certainly seems like it. Seems like it's one of those inflection points for the industry, for healthcare and all of its adjacencies, to really think differently about how we meet patient need. The constraints of physical and social distancing, the consumer sentiment, reluctance to seek care, to stay at home. All of those things have really allowed both an incredible amount of innovation and an acceleration in things that we all know have been possible, but haven't been well adopted or scaled or reimbursed in the healthcare space. So I'm very optimistic that given the duration of this, we're coming up here on our second month in Ohio, that some of those things will endure. It's almost reset or rebased expectations in terms of what's possible, what's safe, what's effective, and in some ways more convenient. I think most people want to get out of their house and enjoy what's supposed to be nice weather this time of year. But I do think we're going to see a lot of changes in healthcare for the better. The reality is, with pent-up demand and people not seeking care, they'll probably take a little time to figure out what that new normal is going to look like. There's a fair amount of pent-up demand that'll need to be serviced quickly, and then there's patients with chronic disease and other risk factors who've been sitting at home and reluctant to seek care are gonna obviously be hitting our doors soon. So new normal for sure, but remains to be seen how that shakes out.
So Eric, we never know how people are going to react to a crisis. You are an EMT before you became an emergency room physician. You're hardwired and you're trained to run into the flames, but certainly not everyone is. And we're surrounded by people who, possibly due to luck or age and stage, have never had to experience or participate in crisis reaction before. Of course, I'm unabashedly steering the witness here with this question, but what have you observed with regard to the way in which UH has reacted to this, to the city, the region, but maybe with a specific focus on the people that you're surrounded with on a daily basis?
You know, in Ohio, fortunately, we don't experience natural disasters or large-scale emergencies, pandemics, et cetera, with regularity. And so on one side, we're fortunate in that way. The downside, of course, is that we don't exercise those muscles. We don't have deep learnings in that space. It's not sort of embedded in our culture the way it may be in other countries or other states that have more frequency to employ the approaches. I will say it's been a learning journey for us. In fact, it's sort of the quintessential model for innovation. How do you build the plane while you're flying it, iterate quickly, fail fast, course correct, incorporate learnings into the next version. So it's been a wonderful way to accelerate a culture of innovation, albeit in the midst of a fairly scary reality. But at the core, David, I've never been so proud of an organization in terms of the esprit de corps, the selflessness and sacrifice of all of our team members, the frontline clinicians, the people working behind the scenes to make sure we have what we need where we need it. Just an unbelievable rallying to the needs of our community here.
Let's stay on the innovation theme, Eric, if we could. Jennifer alluded to the fact that made the decision to redeploy its innovation mechanism and machine towards a series of unmet needs. We know of other systems, whether it's an issue of cost cut or liquidity preservation, they've in fact gone in the other direction, and certain departments have been sidelined or furloughed. We chose not to take that tact. Maybe talk a little bit to the activities of the redirectionalized, the redeployed innovation platform at and what some of those outputs and outcomes have been.
Yeah, well, I can start. You have intimate knowledge of some of the front lines, so I may ask you to double click on a few of these. But, at a high level, we asked our organization if they would be willing to be redeployed in creative ways to put their innovation hats on and say, how can we solve some problems that are staring us in the face? And the first and foremost on that list was personal protective equipment and how we might accelerate crisis and contingency supply, partnering with local manufacturers, reimagining cross-industry strategies and prototypes, and then being able to rally not only our internal team in that regard, but partners in the community, philanthropy, and a fair amount of venture activity going on, sort of the right opportunity, unmet need in the market. So sort of a nice social impact, compelling opportunity beyond the innovation itself. From clinical delivery, research therapies, the remdesivir drug, and we were the first institution to be an approved site there, to some of the more exciting things regarding technologies to help keep our at-risk population safe, remote monitoring in the home. We had a really interesting strategy that's matured now with Massimo to put home monitoring in place for patients, getting them out of our hospitals and continuous monitoring. And then a couple of our own portfolio companies have been able to really shine here. One really focuses on sort of the peripartum period, women who are in the delivery phase of their pregnancy, and how we help to put algorithms and decision support tools in the hands of our clinicians. Very high risk population, very vulnerable group, and so RiskLD is a portfolio company of ours that's really stepped up here. And then the other is TempTrack, which is a fantastic technology we've used historically to do continuous temperature monitoring around some specific use cases, our oncology and cancer service line population in particular, and now is being able to support continuous monitoring of employees and healthcare workers, as well as others. But David, why don't you double click, the PPE Alternatives Task Force that UH Ventures has been leading is unlike anything I've ever seen in terms of the activation in our ecosystem. Maybe highlight a couple of the key points there.
Sure, happy to, Eric. And I think to underscore a couple of things that you said earlier, rank, experience, backgrounds, those all fell by the wayside. People raised their hands immediately to lean into how they might be of assistance to UH, to our frontline staff, and of course to our patients. And it was that breaking down of barriers and that elimination of traditional friction that I think enabled us to in a sense go to market very quickly. I for one knew nothing about face shields and dip molding gloves and 3D printing swabs, the manufacturing of gowns, the technologies used to 3D print to injection mold face shields. We all became quick studies, obviously with the support of industries large and small in our ecosystem. And very rapidly, industry raised its hand locally. Some of these were national and international companies as well, to say, what is it that we might do? And candidly, we often started with a blank piece of paper. We partnered with our supply chain team. We made a quick determination from the perspective of anticipated shortages based on burn rates. We used that modeling to then back into what we thought were our priorities and the sequence of activities that we would need to embark upon to fulfill those unmet needs. And more often than not, the solution came from a non-traditional source. Entities that may not prior to this have been manufacturers of medical grade equipment, designers and engineers who candidly traditionally worked on pure industrial applications and outputs. They pivoted pretty quickly, and we were amazed at the pace with which we were able to rapidly co-design and co-develop for the likes of and co-source for the likes of face shields and swabs and gowns and any number of the other SKUs that were projected to be shortages. And then finally, I would add to that the mention you made of the redeployment of existing technologies into new use cases. And in fact, in some cases, it would appear that the COVID-19 related use case is probably going to be the prevailing outcome for some of these entities and companies. So let's talk, Eric, for a second about what it might look like in the new normal. We're all beginning to pivot towards what re-engagement looks like from the perspective of the delivery of healthcare, obviously parallel tracking that to how all industries are looking to their response. We're here in Ohio. By many measures, the severity and the impact for us has been somewhat blunted, and some would say that could be as a result and function of a very aggressive and rapid response from state leadership, making some science-based decisions. But now we're getting close to some synthetic dates on the calendar. Early May, businesses are going to start to be permissioned to reactivate. What concerns you? We infer a lot could go wrong. We may have avoided the severity of the first surge. There's a lot of concern with regard to what might be if, in fact, the reemergence is unchecked.
Yeah, it's a great question. I spend a lot of time in discussions about that and thinking about that. The expression of the pandemic across the state of Ohio has been different than originally conceived. The early understanding was that this would be a large sort of tidal wave type of surge scenario, hitting all hospitals within a region relatively simultaneously. What we've actually seen is, again, likely because of some very aggressive policy gestures from our state government, we're seeing a much flatter curve, with the exception of cluster outbreaks in congregate living facilities. So these are high risk for a couple of reasons in terms of the population demographic. These are addresses with relative density of people inside a single address. So congregate living would include nursing facilities, assisted living, group homes, high density senior housing, multifamily units, or even correctional facilities. And in these settings, there is oftentimes an inability to physically distance one person from another. They also tend to have a relatively higher disease burden at baseline in the population. And so putting those two together, we've actually been leading some statewide efforts to really lean into that particular sort of mogul field of cluster outbreaks. How do we dispatch resources and teams to test in place, to treat in place, remote monitoring inside those facilities to try to help stabilize, slow the spread when slowing can't be accomplished? How do we really engage with patients in a dignifying way to understand goals of care, et cetera? So bringing, mobilizing testing, remote monitoring, in some cases when employees in these types of settings have been impacted, buttressing them with staffing. So another redeployment strategy for our clinicians has really been how we've been able to tackle it. So fortunate in many ways that's translated into a relatively low occupancy rate in our hospitals. Means we've got a lot of clinicians who can be redeployed against other work, helping to support the recovery, and then helping to really go after these cluster outbreaks in the congregate facilities. So put a fair amount of investment into that, both with tools, technology, process, and people, and it's now in sort of diffusion mode across the state.
Talk to us a little bit, Erica, about telehealth and remote monitoring. Obviously, their days in the sun have come as a result of this. Do you infer there's going to be a mean reversion back to the old face-to-face encounter modality, or do you think the adoption and the traction that we're starting to see by virtue of necessity right now when it comes to remote monitoring and telehealth, do you think that that's here to stay? Obviously, a lot of startups will be listening to this. This could be insightful from the perspective of how they think about their value propositions. Talk to us a little bit about that.
Yeah, you know, it's amazing. I think broad strokes, obviously, we've redefined what's safe and effective, and as this endures for a period of months, really hard to argue that we can't continue that from a feasibility standpoint. The Midwest, in particular, has been a late adopter of telehealth and virtual visits, and this has obviously challenged us to play catch up relatively quickly. You know, an interesting stat from our system, we actually are almost back just shy of 100% of historical volumes, and it's a mixture of in-person and virtual visits. So we went from, you know, being sort of a minority of our activity and encounter volume to now the majority. So it's pretty impressive. You know, remains to be seen how that endures, particularly from a reimbursement standpoint, which has always been one of the obstacles to broad scale adoption. But you know, happy to see that really being embraced, remote virtual connectivity with consumers. And the feedback from consumers is that you know, for the types of care and services that are amenable, those are great options.
I get concerned with the risk of history repeating itself. Shame on us, the collective us, if we don't learn lessons from this. What do you think we or healthcare or providers in general should do differently in anticipation of the future inevitabilities? Is that stockpiling? Is it additional desktop exercising? How do we sustain some threshold of readiness so that it's not a standing start if and when this happens in the future? And you know, I know other countries think about this differently. They put themselves in a sort of semi-readiness state at all times. What should American, U.S. Healthcare systems do in preparation?
Yeah, you know, good question, David. I think one thing we're seeing here, and it's sort of ironic, plug and play has been sort of a really fuzzy edge, a collaborative vehicle in Northeast Ohio between the major health systems. Our neighbors at the Cleveland Clinic and Metro Health, for example, have been partners with us in the plug and play journey. And historically, that's where a lot of the collaboration lies. This pandemic has brought all of our neighbor institutions together in a battle rhythm of activity on a daily basis, coordination, data sharing, competency, leverage to really respond in a way that's ecosystem driven as opposed to healthcare institution driven. And while that's alive today, I think it could be a wonderful accelerant to our innovation strategy here in Northeast Ohio. I suspect that's true and relevant to other parts of the country, other parts of the world. Certainly the stories from our peer institutions that we're benchmarking with by phone and by video on a weekly basis tell us they're seeing similar cross-competitive partnerships forming, and those are really fueling the opportunity for innovation, I think, that comes out of this. The other piece, I think, is really about supply chain and how we diversify our supply chain, how we stabilize it in the near term, and how we think maybe a little differently about what is supply chain security look like, and what's the value of security and diversification relative to just sort of the most efficient or the most economically cost-effective strategy. So those are the two that are really hitting home at this point from my perspective. The supply chain sort of reimagination of success and the collaboration with our institutional partners here in town.
Eric, it's no secret that the financial impact for healthcare, for hospital systems, certainly the financial impact for all industries is potentially debilitating. And to some extent, there's the real risk that not everyone survives this from a financial perspective. How should hospital systems think about balancing the needs to invest in innovation, which usually has a long-dated tail to it? It has a return horizon that doesn't neatly fit into annual fiscal cycles, et cetera, versus the enormity of their current gaps, their current needs. How do they think about deploying dollars right now and potentially deploying dollars in the future in anticipation of the need for innovation to insulate and protect us?
Yeah, that is ironically the one thing I wouldn't have predicted about this pandemic is the true increased velocity of innovation and related activity, adoption of technology, the speed at which we're able to pilot new technologies and tools inside our organization, the way we're able to take an idea and translate it to a prototype and iterate over the course of days, to stand up a new clinical trial overnight. These are processes that oftentimes in large institutions would take weeks or months. The nimbleness, the agility that's come out of this, I think, is really an amazing opportunity. So ironically, we're seeing more innovation output on any measure or dimension during the pandemic than perhaps we've seen in a concentrated fashion historically. So optimistic about that. I think the rationalization of the realities in our economic state, both at a macro level, regionally, nationally, and then here locally, we've had to tighten our belt. We've trimmed hours where we can, when and where we can keep our frontline folks engaged. But we're also making thoughtful investments in our future, and that's really thinking about what consumer sentiment will look like post-pandemic as we come back online, really thinking about how to augment our virtual strategy. And the reality is with the non-essential surgeries in Ohio being postponed, how we bring that online and balance the economics from that with our need to make some longer range bets in the future. Whether it's constraint driven or whether it's strategic, I think there's a wonderful opportunity to make some thoughtful investments in those opportunities that have long-term dividends.
You know, a quick data point, you talked about the velocity of innovation during this time of crisis. We have received more innovation disclosures in the last 7 weeks than we did all of last year. So it's bearing out in terms of, now of course the challenge is to make sure we appropriately respond and adjudicate to all of those, but innovation and crisis have certainly bisected to bring out the best. There are a couple of questions, and one of the first questions, and I'll hand it back to Simon as soon as we get through this question, Eric, but the notion of when we'll begin to re-embrace and re-accept elective procedures and what that might look like from our perspective, knowing that you know, we're an N of 1 in that regard based on our idiosyncrasies, but any commentary in terms of what University Hospitals is anticipating with regard to well visits, elective procedures, et cetera?
Yeah, so you know, I used the stat a moment ago about, you know, some volume starting to get back to near baseline. That's really outpatient visits that can be replaced with virtual encounters, video, telephone, et cetera. You know, we're seeing, as the rest of the country is, you know, 70% reduction in elective or those procedures deemed non-essential under our state framework. And that's something we're hoping to be able to resume in a phased fashion starting May 1st. Probably won't be everything. It'll be a very organized queuing. The reality is there's scarce testing capacity, and so how we leverage the finite capacity to ensure safety for not only patients, but also healthcare providers and the broader community. The good news is, as a country and as a state, and certainly here in our institution, we're ramping capacity every day, rapid testing capacity with Abbott, our standard PCR testing for COVID, and then we'll be working on an antibody-based strategy here in the coming days. So collectively, it's not perfect, but we think that that'll really help to set the pace in terms of how quickly we can sort of get back to normal. And that's, I think, the collective thinking, you know, in our peer group.
Eric, appreciate you taking this time to step out of the command center and share some of your experience and your knowledge and wisdom with the listeners. And perhaps with that, Simon, I can hand back to you for a couple of the questions that have come through.
Yeah, fantastic. Terrific conversation. One of the interesting things that you guys started with was how the system rallied together with the command center. And one of the interesting things one of the questions here is in terms of the linkages that enables the system to move forward with the innovation agenda with all of the various internal parties that need to be involved. Could you talk briefly about whether that system had existed before, or was that sort of put together within the command center structure to really move forward with those technologies that you guys have been leveraging to manage the crisis?
Well, I can start. David will have a different vantage point because he was sort of looking at the same process from, you know, outside the command center and how they connected. But the command structure really focuses on 4 big sections: operations, logistics, planning, and finance and administration. And it almost requires us, as we move 24/7, to rotate different people there. So by its nature, we're de-siloing the organization. By its very nature, we're organizing everyone around a shared set of management objectives for a given operational period. And that has a crystallizing expectation for folks of what are we trying to accomplish. So the structure itself really binds people together literally in ways that are sort of one system, one organization, that may not exist there in sort of peacetime operations, for lack of a better analogy. The other piece is that there's a very regimented process to rapid cycle approvals. So, you know, the typical process of vetting a technology or a pilot partner that takes, you know, weeks, months, years in some cases, you know, unfortunately, data sharing, being able to rationalize a slightly different risk tolerance relative to the urgency that's required, sort of speed to market, becoming a more important dimension than perhaps under normal operations. Those really allowed us, I think, to embrace things that would bubble up, great ideas, great opportunities for partnership from all corners of the organization, not just the clinical, not just the supply chain, but literally all facets, as well as from outside the organization with community partners. David, what did it look like from sort of outside the command center?
Well, not dissimilar. It was the mirror image from the perspective of still needing to work through the traditional hurdles and traps that you have to run in order to get a new technology or new process considered and approved, and that takes legal, and that takes IT, and that takes, of course, the stakeholder, and that takes compliance, and to the point that you made earlier, that can be months to a year. Unless there's intentionality, unless there's a desire to do it differently. And I will tell you that the individuals in all of the aforementioned verticals that I just mentioned raised their hands and said, we will get this done, and we will get this done with the right sense of urgency, because without putting too fine a point on it, lives are at stake. And these weren't just one-off initiatives. On a number of opportunities that we have looked at from a technology adoption perspective, days. It literally took days to go from here's an idea to let's turn the on switch. Literally took days, with all of those right traps being run appropriately and all the right approvals and sign-offs. Now, is that realistic and sustainable in peacetime to the point you made? Probably not, because it's a frenetic pace that isn't sustainable. But it probably does portend that it shouldn't take months and years. Maybe there is one of the residual learnings will be some threshold of what does fast track look like, and maybe that's at a less than breakneck speed of 2 months, 3 months. But I'm hoping as a result we don't revert back to the speed of healthcare, so to speak.
Yeah, fantastic. So we've had some really interesting questions around collaboration. You'd mentioned that, Dr. Beck, that you've been on the phone with health systems in the local area, and we had some really good questions around what do you see as collaboration going forward, and in terms of operating as a sort of a regional health system, what do you see as sort of opportunities that might flow beyond this event as we think about managing in the next 3-6 months and even beyond?
Well, it all starts with relationships and a shared purpose, a shared goal, a shared mission. And so, again, historically, we've had a shared mission in Northeast Ohio around accelerating an innovation ecosystem here, leveraging the health system assets, the intellectual capital, the tradition and legacy of innovation in Northeast Ohio to support that. I think now we've got sort of a battle-hardened vehicle with senior leaders at each of the institutions reaching out, building bridges, sharing data, sharing best practices, and the reality is that they help all boats to rise. So I think that there is some of that. The reality is, we have some different goals, and those will reemerge as they should. But at the end of the day, we're serving our community together in a time of need, and have been able to really build those bridges in ways that I'm confident they will endure.
That's great. So you made a really interesting comment about both dealing with the current crisis and preparing for what comes next. And there are some sticky issues around, once elective procedures might resume or otherwise. How are you guys grappling with the idea of having COVID and non-COVID patients within the health system? What are some of the other challenges that you guys are thinking about, whether it's telehealth visits or otherwise in the nearer term as things go forward?
Yeah, it's a really interesting challenge. Kind of comes back to that fundamental principle that there's scarce testing capacity, and the testing capacity we have is really for presence of the virus. And we have cases in which people will maintain a positive test result a month after they've sort of resolved clinically and are asymptomatic. We also know that people can be shedding virus and transmitting COVID-19 without any symptoms. So part of what's elusive is sort of the edges around a positive test result. The other piece is antibody testing, which people have heard a lot about. We're still sort of understanding what exactly that means, what immunity is conferred, how long does that last, and a number of very credible scientific positions that suggest immunity doesn't mean you can't get reinfected. There's data coming out from other parts of the world that suggests you're not safe. Viral mutations, the potential resurgence in the fall or the winter. These are very real realities, and so without more testing capacity, rapid testing capacity in real time, being able to test every really difficult challenge. Obviously, technology can help us really think creatively about how to mitigate or de-risk how we proceed and reactivate our organization. Everything from blockchain tools to helping to really create a record of test results, to things that are much more focused on navigation and being able to cohort patients intentionally. Huge opportunity for the right innovator and right entrepreneur to rise to the challenge.
Fantastic. And look, just as we land the plane and hop into looking at some of these technologies, I might just ask for you both a very, very short bite around leadership lessons. What has been maybe perhaps the biggest challenge, and what are you sort of most hopeful for as we progress over the next few months? Maybe I'll go to David.
Sure. Leadership lessons from me. Unfortunately, some of what I've been thinking through and looking to deploy from the perspective of how I partner with in a servant leader manner with my team was honed during 9/11 and then to some extent during 2008. Both of those were times when I was in the financial services industry. Certainly different implications and applications and a different breadth of impact. But I think the lessons I continue to learn are that you need to give people time to voice and voice their thoughts, their concerns. Be sympathetic with regard to attempting to understand the frustrations of others, because my worldview is just that, it's my worldview. And I think permissioning people to be what they can be in a time of crisis is very empowering. Permissioning people to actually make and take decisions and to put action into process, I think for me really allows people to manifest the best that they can be. And to a person with regard to the team that I'm privileged to work with, everyone has stepped up to that challenge, Simon.
Fantastic. And Dr. Beck?
Yeah, I would say gratitude. Gratitude for my own safety, for those of my team members, my family, my community. We've been very fortunate, and I think it's easy to take that fortune for granted. So really being intentional about gratitude, and in so doing, being transparent about the real threats, what we know, what we don't know, so that people can appropriately get context and sort of make sense of the path to emerge going forward. But really enjoyed talking with you, Simon, and thanks for having us.
This has been a terrific conversation. So thank you both so much for being with us. And I know that from our audience, this would be a huge amount of value. And so looking forward to working with you both as we go forward. So thanks very much for you both.
Thank you.
Great. All right, folks. Well, we're going to transition into looking at some of the most innovative and exciting, relevant startups, relevant to health systems in particular, as they deal with COVID and grapple with what life looks like in the aftermath. So the way this is going to work is each startup will have 7 minutes to pitch and share their technology, and then we'll have a 1 minute Q&A. Each of these pitches are video recorded, so we'll have the video and then a live Q&A. So please do use the Q&A box if you have any questions for the startups, and we'll do our best to get to those. And of course, we'll provide contact information and connect you with them if you'd like to do that. All right, so our first one is BlueDot. So we'll roll the tape and then we'll hop into the Q&A.
Thank you everyone for your time today. My name is John Shahidi and I'm a Director of Strategy and Growth at BlueDot, a Toronto, Canada-based digital health company. And I am here to talk to you a little bit about what it is that we've built, as well as the work that we are doing to support a wide array of audiences as they respond to COVID-19. So BlueDot largely was founded out of Toronto's experience in 2003 with a different coronavirus. At that time, it was SARS. And what we realized was that there was a pronounced need for a global early warning system that understands not only where epidemic and infectious disease activity is around the world, but can then also anticipate and quantify the risk to a wide array of audiences. So this global early warning system leverages natural language processing, artificial intelligence, and big data to understand where outbreaks are happening. We are filtering through about 200,000 media and public health intelligence pieces per day to understand what the world looks like from an epidemic perspective. What we're then doing is understanding how people are moving locally as well as globally so that we can anticipate and later quantify the risk of spread from a particular pathogen or from a particular outbreak to another location. What that allows us to do is then actually understand impact. So on a pathogen by pathogen basis, if there's an outbreak in one location and it spreads to another, is it likely to be an ember that flames out, or could it potentially ignite a local outbreak in that location? And then finally, what we seek to do is communicate our intelligence, our risk awareness, and our quantified risk calculations in ways that are most effective and impactful to decision makers in government, in healthcare, and in enterprise risk management. So the culmination of this global early warning system is our Insights platform. Insights is the world's first automated risk awareness platform for infectious disease. BlueDot holds a number of patents on this system, and ultimately what Insights does is for 150 different pathogens, it automatically quantifies and stratifies a particular organization's risk from an infectious disease perspective. It's important to note that Insights is highly configurable, and what we seek to do with it is allow people to see their unique infectious disease risk through the platform. So it allows you to see a lens into your own world from an infectious disease perspective. Insights has a powerful data warehouse that supports it, everything from global air travel to local mobility to global infectious disease coverage in both media and public health, as well as 37 other contextualizing data sets that allow us to anticipate both spread and impact. Insights users were among the first in the world to receive a notification of COVID-19. We pushed a communique through the platform to our users on December 31st at 10 in the morning, identifying a cluster of mysterious pneumonia cases emanating from Wuhan in China. Immediately after publishing on the event, our team got to work, and as part of all of our Insights and software subscriptions, we supplement that with research from some of the leading experts in the world who happen to be on our team and helping us build our products. So on January 8th, we published a detailed spread analysis identifying where the pathogen was likely to go to, and this proved to be highly predictive over the 3 weeks that followed. Since then, as part of our Insights platform, what we are allowing our users to do is answer additional questions that can help calibrate their response. What does the world look like from a transmission perspective? Which places have likely not yet detected cases or have underreported cases? What are hotspots today, and what are hotspots in the future? What do particular outbreaks look like from a COVID transmission perspective, as well as from other leading indicators like degrees of social distancing, so that we can better anticipate how effective policy measures are today and will be as we start to relax them in the future. Questions that you can also answer here are: where is there likely to be a second wave for an outbreak? What is the next epicenter going to be? These are all key questions that decision makers across public health, healthcare, and in enterprise risk management need to be aware of. Ultimately, what we are seeking to do is help a broad array of organizations, one, better anticipate their infectious disease risk by being the first in the world to alert them to risks that they might face. The second is understand how those risks are likely to unfold. That is through an understanding of the current situation on the ground, how the pathogen is likely to spread around the world, and what impact might it have. And ultimately, what we're seeking to do is help a wide array of organizations be able to better protect their populations, better protect their employees and customers, and better mitigate operational disruptions that infectious disease risks might pose. I just want to leave us here with this thought, and that is that the fact that COVID-19 has emerged is not a surprise. We knew that the world was at risk for a major pandemic, but given the sheer level of disruption, human consequence that this has had, as well as economic consequences, it is incumbent upon us to better prepare ourselves and build more resiliency for society and the economy going forward. Thank you so much for your time.
Great, and I believe we've got John Shahidi, the Director of Growth and Strategy for BlueDot with us. Hi John, how are you?
I'm well, how are you?
Good, thanks so much for joining us. I've got one question here. Could you tell us a bit more about the business model? I see you've got some government clients, some private clients, it looks like. Is this open to anyone, or is it B2B?
Yeah, so very much so right now what we're focused on is a B2B approach. So we employ a pretty basic kind of business model, which is kind of your standard software as a service licensing package. This applies to both of our products, both Insights and Explorer, which is developed for more of a niche public health kind of subject matter expert. And both are sold on a per user, per year kind of model. And yeah, these are just kind of a select group of some of the clients that we're working with around the world.
Fantastic, and we've got time for just one more. And in terms of the capability for predicting future events, can you talk about like how quickly is it to get up to speed? How does that work from a customer point of view?
Yeah, absolutely. So I'm going to answer this quickly, but there's a lot of kind of depth to this. But broadly speaking, what we're leveraging is artificial intelligence to scan through hundreds of thousands of pieces of intelligence every day. So we're picking up things like, a local newspaper in Hubei province, them publishing, or healthcare worker blogs, things like that. So we're doing that scanning every 15 minutes or so. Those are then pushed to our in-house clinical team, who review it for accuracy and ensure that what we're publishing is in quote unquote fake news. And then what we do is we publish that. That whole process takes between 3 and 5 hours, but it still puts us, very far ahead from other kind of publicly available sources.
Fantastic. So that's all we've got time for, but really, really nice cogent questions. So thanks very much for being with us, and we'll hop on to our next one. So folks, we've got Informatica is going to be our next startup, and without further ado, let's hop into the video and we'll do the Q&A afterwards.
Hello, my name is Amy Window. I'm head of sales in the US for Informatica. We are an AI company focused on improving the triage and diagnostic process by using the most advanced reasoning technology. I'll give a quick overview of what we do and then focus on our COVID-19 risk assessment tool. We were funded in 2012 in Poland, and we are now a US entity company. We have over 50 clients in 20 different countries and have provided over 5 million checkups. We have a wide variety, as you can see, of deployments, including insurance companies, health systems, telemedicine companies, and other health tech clients. Early triage can really help in many different ways. Patients can find the right care quickly. It can help healthcare professionals save time on data entry. and also help health systems and payers prevent leakage, really by directing the patients to book appointments or telemedicine or keep the ED from overcrowding. We have 3 different solutions, first being our symptom checker. It's basically there to guide patients, obviously, to the right point of care and can be embedded within a website or an app. A patient basically will add symptoms. You can see this is a white labeled product. This is one of our clients, Allianz. Our AI engine will then ask questions regarding what they've entered or what the patient has entered and risk factors. And then the outcome will direct the patient to the right point of care, from home care to telemedicine or to the ED. At the end, a summary can also be provided to the doctor and can help that physician with differential diagnosis. We also have call center triage, which can be used by clinical or non-clinical staff. While triaging patients, by the phone, they can quickly get through this interview and then direct them to the right point of care as well. We also have all of this available through our medical API. It can be implemented into third-party software that way. Many of our clients do this that have a lot of customization requests. It is a true AI engine, but it's also based on curated medical literature, publications, and data sets from trusted places like the CDC. We have a 93% accuracy. That's on case reports from British Medical Journal, New England Journal of Medicine, and others. And there's been over 30,000 hours of physician review. So when the COVID outbreak happened, of course, we wanted to help. We use our engines to build a risk assessment tool for anyone to use for free. Companies can embed this in their websites or applications. The tool asks specific questions related to a patient's symptoms, exposure, and risk factors. The links in these slides are active and available for you to check out. There are 6 different levels of triage that are clearly stated at the end of the assessment. There's a detailed advice on what to do next. And then also we provide local phone numbers for health authorities, should they need to contact them. The risk assessment tool is separate from our symptom checker and built only on guidelines from the World Health Organization and the CDC. It's also currently available in 20 different languages, and we're adding more every day. Companies are able to embed this into a website or an app. They can even use our APIs to integrate it into a third-party solution. We also have it available on our symptomate.com website that's free for anyone to check out. In the past few weeks, over 300 different organizations have installed the risk assessment tool and have had ease of use doing so. So thank you, and I'm happy to answer any questions you may have.
Fantastic. And I believe we've got Amy Window, the US Head of Sales here, and we just saw you on video. How are you, Amy?
I'm good. How are you? Thank you.
Very good. So we've got one question here. Could you tell us a little bit more about maybe a case study or an example of a customization project that you've worked on for a client?
Yeah, we've done something recently with Roche Diagnostics, that's really definitely a customization piece that we did, really helping with their clinical decision support piece of it and helping to determine what type of labs might need to be taken based on the patient's symptoms. So that's just a real deep customization that we did with them. So we have, because of the API capability, there's a lot of different workflows and different solutions that can be done with our symptom checker.
Fantastic. And we just have one more here. Can your tool help patients or consumers determine if they need to pursue an elective surgery based on their conditions, potentially ultimately expediting scheduling processes?
Yeah, I mean, it's basically meant to be able to put inside a workflow completely on its own or inside like scheduling, like so that our links can go into a scheduling app based on what the potential outcome or potential disease they might have. It can also link them to specialists So there's a lot of different customization in that can happen.
Fantastic. I think that's all the questions. So, but thanks so much for joining us, Amy, and we've got the poll up for folks to get connected to you afterwards.
Thank you.
Cheers. All right, folks. So the next startup we have is Vocalist Health, and we've got Tal Wendero, the president and CEO, to join us on the Q&A afterwards. So we'll roll the tape, and then we'll hear from Tal.
Hello, thanks for having me participating in this exciting Plug and Play event. My name is Tal Wendero. I'm the president and CEO of Vocalist Health. Vocalist Health is an Israeli-based startup, headquarters here in the Boston area where I'm located. What we're doing is using voice to monitor health, which is extremely important, especially in the COVID-19 era. Voice is an underutilized biomarker. We, as a healthcare system, so far did not standardize and quantify the voice that we use traditionally to diagnose patient, to look at our loved one. And we, as Vocalist Health, we use voice as the first line of defense. And we leverage the characteristic of the voice as a non-invasive, passive, and scalable to provide insight about the individual and about the people. Our solution is a software-based only. We analyze the voice. We don't listen to the content, but only the acoustic. And while we run an old voice platform, our first focus is a mobile app that allows us to provide actionable insight, whether it's for the healthcare professionals, the payers, the insurance, and the like. Strategically, we're building the company in 3 layers. The first layer is multiple vocal biomarkers, focusing on our respiratory and COVID-19 biomarker that we are about to unveil, our vitality vocal biomarker, which is correlated with the risk of hospitalization and mortality of chronic patients, and early results that we have on depression, alcohol intoxication, and others. Our core pillar is our voice technology that allow us to analyze the voice using sophisticated machine learning and deep learning algorithm, and we collect voice, whether it's from your home, your car, your mobile, or your assist device. And on the right side is our customer offering, which is specifically built to apply multiple customers, but more importantly, we're all aware that there is a consumer in the end, and we built our solution to be user-friendly and scalable. Till March 1st, the company was focused entirely on the telehealth, on the remote patient monitoring, and how to provide information about the patient when he's not near the physician, whether it's before the visit or after the hospitalization. Even today, when everyone shifted from office visit to telehealth, the challenge is a tsunami of telehealth calls bundled with the shortage of healthcare professionals that they don't have time or the bandwidth to manage all these patients. What we're doing is leveraging the voice to triage, detect, and manage patients with a goal to triage and automate those telehealth calls and allow the physicians or the nurse practitioner or the physician assistant information about those patients, and by that make the right decision how to treat those patients. On the right side is our biosecurity. As you know, the challenge is not only how to manage TAL, but also how to protect the society if I'm, God forbid, sick. So when we think about biosecurity, temperature check is not sensitive or specific enough. When you look at data, whether it's from New York, Italy, or Iceland about the COVID-19 patient, roughly 25 to 30%, if not more, of the patients admitted to the ICU are present without any fever. Our goal is to unveil a vocal biomarker that is more sensitive and more dedicated in temperature to serve as the first line of defense in the fight versus COVID-19. Let's think about product for a second. We're a pre-commercial company. We're about to launch pilots right now to quantify our offering. Our solution varies from take a voice sample and provide insight about that individual with our detectors that we already have age and gender in high 90%, working on pulmonary hypertension based on a clinical trial we've conducted with the Mayo Clinic, sleep apnea, and others, to provide insight about an individual disease, medical condition, and utilize the voice as a passive thermometer. And for that, we built what we call the voice health score. In the middle of track is our ability to not only detect deterioration in chronic health, and our first use case is shortness of breath, but also provide predictive analytics on acute events to manage the disease at home. And on the left is our ability to triage chronic patients based on a single voice sample. Going back to COVID-19, we're in the midst of a COVID-19 study that we capture patients at home and at the hospital with the goal to, one, be able to manage the disease at home and keep those mild and light symptomatic patients at home. And secondly, flag whoever needs to get tested, whether to find information about themselves or, as discussed before, help going back into business, open the country again, and getting sophisticated and dedicated insight who has higher risk of COVID-19, and by that triage them for faster testing. Just to show you how it works, and obviously we have a demo as well. You're doing a voice recording on the app, answer COVID-19 questionnaires. We're adding right now the ability to insert vitals, and the physician or the healthcare professional will have a dashboard to allow them to manage their patient. This is in the case of telehealth, and that they will come to those telehealth calls more prepared. In the biosecurity, to raise a flag, that will be embedded into solution out there, whether it's your boarding pass, whether it's before you go back to school, and how do you create that dedicated, personalized voice signature to tell about your health. To summarize, our solution allows to multiple vocal biomarkers. We have a proprietary asset of voice data and a very sophisticated voice platform, ISO 13485 certified, that allow us to provide our offering to multiple customer levels. And we intend to go to market in the next couple of weeks and months. Thank you very much.
Fantastic. And Tal, thanks so much for joining us today. How are you?
Good. How are you, Simon? Thanks for having us.
Good, very good. I got to remember we're in different time zones around the world here. I've got one really good question around use cases and the clinical validation. In which use case is the clinical validation strongest that you're targeting, say, for launch in Q2?
Right. The first use case for us is the detection of shortness of breath, and this is our low-hanging fruit, our entry point. We have data that from prospective and retrospective clinical trials we've conducted both in the US with Geisinger and in Israel. And the second use case is the triage of chronic patients that we have publication that was just released last month in the Journal of American Heart Association, along with Mayo Clinic and the Sheba Medical Center.
Oh, fantastic. And in terms of, how large is your data set, and, what do you need to get the product to market as soon as possible?
Yeah, so if you ask the data science, they always need more data, right? So it's a trick questions, but we have more than a million voice recording and 50,000 patients overall, both retrospective and prospective. We continue to both launch pilots, and we're actually actively launching pilots right now, both in the US and in Europe, and also doing clinical trials to continue to unveil new vocal biomarker, whether it's for pulmonary hypertension that we have early result or others, to continue to collect more and more data.
Fantastic. And is there, just very, very short, any deployments that you've got right now ready to go for Q2?
So if you ask me in 2 weeks, the answer will probably yes. Right now we're aligning those. We're in the company's in the sprint just to release the final version. But we're excited, and if anyone wants to join us, whether for a pilot or for a clinical trial or even an idea about how to use voice, we see voice as the sense of the body, right? So we'll welcome any inquiries. Feel free to reach us, and we'll be happy to collaborate.
Thanks so much, Tal. Really appreciate you being with us today. And we've got the poll up for folks who like the interaction. So thanks very much, and we'll catch you soon.
Great. Thanks, Simon. Appreciate it.
Awesome, Tal. All right, folks, so next up, we've got Retrieve Medical with Dr. Mark Rosenberg as the chairman. So we'll come back for the Q&A after we play the video. So let's play the video.
I'm Jerry Swan, CEO of Retrieve Medical. I appreciate the opportunity to share our breakthrough technology, which we feel will revolutionize healthcare in the emergency room. Our software was developed at Stony Brook University by Dr. Mark Henry, head of the ED, and Karen Chase, head of the CDI department. It took 5 years to develop and it has been used very successfully for the last 5 years. The original objective was to improve the confusion and coding in the CDI department, as well as improve patient outcomes from an emergency room visit. This was done very successfully, resulting in substantial increases of CMI and leapfrog scores at Stony Brook, as well as substantially decreasing Stony Brook's mortality index. I'm happy to say that Karen Chase has now joined us as our president, along with Dr. Mark Rosenberg as our chairman. Dr. Rosenberg currently runs one of the busiest EDs in the country, and his participation is very important to us. Our software is very simple. It solves a very complex problem by substantially reducing the confusion in the CDI department, resulting in better coding and better patient outcomes. So how does it work? When a patient enters the emergency room, our software culls through all the patient's historical records and any comorbidity that violates the CMS rules is deemed to be irregular, instantaneously appears on the screen of the physician. So now the physician is in a position to make a better diagnosis, resulting in better patient outcomes. The doctor no longer has to rely on what he observes and what the patient shares with him exclusively. The present on admission concerns are addressed with a more thorough diagnosis, and the CDI department has more quality information for coding. Physicians can be trained in minutes. We don't interrupt workflow, and physicians spend less time, not more time, with patients. For any interested parties, we can arrange a demonstration of our Retrieve medical software. With that, I would like to introduce our chairman, Dr. Mark Rosenberg.
Mark Rosenberg. I'm chairman of Retrieve Software, and I'm also a physician, president-elect of the American College of Emergency Physicians. American College of Emergency Physicians, I represent 40,000 emergency physicians nationwide. And as president-elect, it's important that I value what's important to an emergency physician. 3 things that this software does. 1, it improves clinical documentation. Number 2, it improves my documentation to make the chart a better risk management chart. And number 3, it actually makes emergency physicians' job easier and at the same time improves documentation. Also, I'm chairman of emergency medicine at a large medical center, and revenue cycle is important to me. So there's 3 things the software does for revenue cycle. It improves case mix index. It improves documentation of present on admission, therefore decreases denials. And it gives me better documentation of comorbidities, and therefore expected mortality is better documented. So if somebody does die, and we know it's from the comorbidities. Let's take COVID-19, for example. We know that people who die from COVID-19 tend to have more comorbidities. Using this software, it will go through the medical record, identify all the comorbidities that the patient has, and make it much easier to identify risk, a benefit of different treatments, and the risks that somebody may actually succumb to the disease. Comorbidities become very, very important in this disease. It's always important to document because it talks about the complexity of care and the complexity of medical decision-making. But in COVID-19, it's critically important to give the best care to a patient, identify their risk, identify the benefits, and make sure you're taking care of the patient.
Fantastic, and very happy to have Dr. Rosenberg with us this morning. I think, Dr. Rosenberg, I saw you before. I think your video's turned off, but I think your mic might be working.
My wife, it is working, I believe. Thanks for having me.
Fantastic. No worries, pleasure. So 2 questions. First, could you just talk quickly about, I'm assuming this integrates with EHRs and other systems. And the second one is perhaps you could just quickly walk us through a real life scenario or case study where Retrieve made a real difference.
Sure. This interfaces directly with current electronic medical records like Cerner and Epic, where right on the medical record there is a key or a place where you click and the software is instantly launched behind the scenes, so it does not interfere with the medical record. But let me give you an example of a case that presents to the emergency department. Every single day a case like this will come in. A 56-year-old male who comes in with relatively vague complaints, maybe a viral type complaint, flu-like symptoms. Most of the time, those patients can be treated as an outpatient receiving some symptomatic relief and being discharged to follow up with their doctor. But in this case, we run the software and we identify the fact that the patient has significant comorbidities. Not only is the individual obese, but has hypertension and has an anemia that is related to a long-standing lymphoma that they had. Mm-hmm. Further questioning identifies this person is at significant risk for bad outcome if this viral illness turns out to be COVID-19. By simple testing and aggressive follow-up, maybe with telemedicine, we can make sure that this patient is safe and has aggressive treatment to make sure that they don't succumb to the disease. Without this, they could have been treated like anybody else. It improves quality of care, documentation of care, and therefore the financial aspect of being able to collect for the care and the treatment you give.
Terrific, thanks so much. And just real quick, last quick question just came through. How many sites do you currently have live? What's on the roadmap?
Currently, we have one site, which is Stony Brook Hospital. We've had it there for 5 years and had tremendous success increasing revenue cycle and money to the bottom line for the hospital and the institution. And now we're just starting to try to put it into other hospitals. We just got our second one just 2 days ago.
Fantastic, awesome, good news, congratulations.
Thank you so much. Great afternoon.
Awesome. Well, look, Dr. Rosenberg, thanks for joining us, and we'll hop on to our next startup here this morning. Thanks for being with us too.
Thank you.
Great. All right, folks. Our last startup for this morning, we've got Jeff Dunn, who's the CEO of Redibus Health, with us. So we'll roll the tape, and we'll have a Q&A with Jeff after that.
How's everybody doing today? My name is Dr. Jeff Dunn. I'm the founder and CEO of Redibus Health. Coming to you from Kansas City. Redibus was founded by 5 physicians, and the mission is to really optimize patient safety during time-critical events. What I observed as a hospital-based doctor for nearly 10 years were the times where I made a mistake or error was when the adrenaline and the chaos in that room was at an all-time high. Cardiac arrest, a patient's heart stopping, a patient stopped breathing, a septic shock patient, a stroke patient. All of those opportunities are times when we receive the proper amount of education, but we particularly during those times freeze up and sometimes omit something, make the wrong decision, or just flat out make a mistake or error. What we're hearing from our customers is COVID has caused an increase 2 to 3 times the amount of cardiac and respiratory arrests. So we want to be at the forefront to help the frontline providers, docs and nurses. Another tidbit that is somewhat eye-opening is the data suggests and research suggests that 30% of the time cardiac arrests have a mistake or error made in the hospital. So what can we do about this? We are very firm believers in checklists driving high reliability in the aviation industry. We all read the book Checklist Manifesto by Atul Gawande, very much has influenced us. And we said, what if we took the idea of a 3D checklist, if you will, merged it with a GPS application where you're getting the turn-by-turn navigation from A to B, calling it a clinical GPS, really. Automating the clinical guidance, the real-time documentation and data aggregation, and the reporting piece really are the core pillars of what the solution does. It's also platform agnostic and can be launched from any form factor, including a phone, a tablet, or a workstation. How does it work? When you hit that blue button on the wall, the red button or the blue button, the code blue button that causes an emergency in the hospital, what typically happens is when that button's pressed, there's about 10 or 12 people that swarm to the room like bees. The senior doctor and the nurse work hand in hand together. The doctor, he or she, is making the decisions off of their memory, sometimes 50 to 60 decisions. And the nurse is there to document everything that's happening and time all the medications and the CPR that's given. What we want to do for that event is to take that and turn it on its head and say, once you push that button on the wall, that you launch our solution, and it literally gives you the simplistic and intuitive nature of a turn-by-turn navigation system. And the nurse is using this to not only document in real time, where he or she could be writing on a piece of paper or a napkin, etc. Not only does it support the documentation, but it supports the clinical guidance piece of working elbow to elbow with the physician to make all the right decisions and not make a mistake. This is all wrapped up into a report that seamlessly integrates into the EMR if you'd like it to. And we have structured data and data analytics to take a look at 100 cardiac arrests and what the quality improvement piece is on that. So ultimately, increase evidence-based compliance during emergencies, documentation accuracy and efficiency, and QI and reporting data analytics. What this is a container. It's a container that has clinical modules that can be launched from any form factor, despite a connection or not, gives you the ability to share it with others and make all the right decisions during these emergencies. It also has a task manager that's so important, and it can support bidirectional data in and out of the EMR. What we're currently looking at is we are giving away our cardiac arrest solution for free right now because we are made up of doctors and nurses and feel passionately about wanting to help what's happening right now, the emergency, the pandemic. And also our EMR integration partner has told us that they will also do the integration work for free right now. It typically takes 4 to 6 weeks. But we're also trying to spin up this idea of creating clinical guidance, real-time documentation, and the data analytics and reporting piece around COVID. Focused around the hospital, this also could be launched in the post-acute care as well as EMS, but this idea of screening, symptom screening, diagnosis, treatment, as well as data aggregation, analytics, reporting, and then care continuity, being able to hand this off from environment to environment. So please come with me in helping our frontline providers make the best decisions on their patients' behalf. And if anybody would like to contact us regarding the COVID provider development, whether that's an EMR, whether that's an acute care diagnostics company or a hospital system, please reach out to me. Thank you for having us.
That's fantastic and really noteworthy around the COVID initiatives. Jeff, can you hear me?
Yep, I got you.
Fantastic. Jeff, two questions. One would be how many folks are using the tool currently? And beyond the cardiac use cases, are there additional use cases you guys are targeting?
Yep, currently we have 10 customers and about 1,000 end users, which is made up mostly of nurses. we are about to sign 2 hospital systems that would bring us thousands and thousands of users with over 40 hospitals for those systems, as well as a strategic partnership with an EMR. So some really interesting and intriguing stuff coming down the pipeline. Your other question was around other clinical modules that we can use. The other, cardiac arrest has been a very popular module to use in the larger hospitals and systems. Sepsis has been one that has also been very successful with the smaller hospitals, as well as some of the mid-sized hospitals as well. So those are the 2 clinical modules. We also have stroke that we've developed out, as well as heart attack that's about 90% done.
Fantastic. Got a question just now around EMR integration. Is it both ways or just one way?
Yeah, so sepsis has bidirectional, so it's pulling in data and then putting data in a note in a reporting piece into the EMR. Currently, the Code Blue does not have a pull of data, but takes all of the reporting piece and seamlessly sticks it in the right person's chart. What we're doing right now is working on filling discrete data fields in the EMR, which is probably phase 2 of that EMR integration. But very simply, this documents that whole 45-minute event, if you will, and puts a nice, pretty report in the right person's chart.
Fantastic. And I'm assuming, well, just a quick question, in terms of organizations who might want to work with you evaluating the value of the tool, how quickly can you sort of show proof of value or at least a concept of value to them?
Oh, very quickly. We've been up and running in some sites within a week, so you don't have to start using it with an EMR integrated solution. As I mentioned, it's EMR agnostic, so just using it takes a couple days to train on it, and that's really our core competency, is simple and intuitive, easy to integrate software. So we are talking to some nursing homes as well that are interested in the sepsis and the COVID development.
Fantastic. All right, Jeff, that's what we've got time for. So thanks so much for joining us this morning.
Thank you,
really
guys.
Appreciate it. Cheers. All right, folks. Well, and I'm going to hand over to Jen. That's the end of our startup sessions. Thanks for having me, and over to you, Jen.
Thank you so much, Simon. So nice to hear from all our startups, and thanks everyone for joining us today. We love having you. Thanks to our speakers, Dr. Eric Beck and David Sylvan, BlueDot, Informatica, Vocalis, Retrieve Medical, Redivus Health. Please be sure to join us next Wednesday if you can, 11 a.m. Eastern Daylight Time for Beyond the Pandemic, where we talk about digital solutions for care management for patients who need continuing care or chronic care. And we will feature our partner, Eli Lilly. And you can also check out our website for even more events. Our recording of this event will be available shortly on Plug and Play's YouTube channel, or you can reach out to me or anyone at Plug and Play if you have more questions. Again, have a great day, stay safe and healthy, and thanks for joining us.